Welcome to EuroPCR 2016. My name is Michael Haude. I'm here with Nick West to discuss a little bit on the use of bioresorbable scaffolds in long lesions. Nick, just by definition for you, what is a long lesion?
Thanks, Michael. I guess it varies from operator to operator. If you take the view that the ACC-AHA type C lesion is anything longer than 20, some people would feel that 20 millimeters is a cutoff. For me, probably somewhere between 24, 28 millimeters would classify as a long lesion.
Why do you think fully bioresorbable vascular scaffolds are a very good option to be used in a long lesion?
Well, I think we've all become familiar with the hazards of so-called full metal jackets. Completely encasing a vessel in metal biologically doesn't feel like a good thing to do. We know there's an increased hazard of restenosis with long lengths of metal stent. There's an increased hazard of delayed endothelialization and maybe stent thrombosis. There's the issue of conformability to the vessel, and probably beyond that, the vessel biology. The vessel's not going to behave like a normal vessel, and there may be increased risk of things like neoatherosclerosis that we've become increasingly aware of.
What kind of procedural aspects we have to consider when we like to use a bioresorbable scaffold to treat a long lesion in the coronary artery?
I think the same things apply to any use of BRS, and that means you've got to optimally predilate the vessel, you've got to size it correctly, imaging if you need it, and post-dilatation to ensure an optimum result. If you don't deploy these right in a long lesion, you're not going to get any kind of benefit.
Can you just explain this a little bit with respect to the lesion preparation, how you're going to do it?
So lesion preparation, either one can be guided by imaging or by eye and use non-compliant balloon with one-to-one balloon to vessel sizing. Clearly for a long lesion it may require different balloons because the long lesions by their very nature vessels often taper, and therefore you may need to use two different size balloons. Low threshold for scoring or cutting balloons, and exceptional cases with focal calcification, maybe some form of debulking atherectomy device.
Probably in longer lesions we have to use more than one scaffold. What are potential problems, pitfalls in the use of two scaffolds to cover a quite long vessel segment?
I think that's exactly right. The current generation of scaffolds, we have a limited size range, and by definition long lesions are likely to require more than one scaffold. There are several issues here. The first issue is that vessels will taper. If vessels taper, with a metal stent we may, if you like, tailor the stent to the vessel with more post-dilatation at the top end and slightly less at the bottom to conform the stent to the vessel. With scaffolds not so easy. There's a notional constraint on this expansion size for all available scaffolds. The other issue, aside of the tapering nature, is the issue of overlap. Certainly for the absorbed BVS and to a lesser extent for thinner strut models, there's the prospect of if you overlap the scaffolds, rather than a thin metallic stent strut, you have two 150 micron polymer struts overlying each other. For vessels more than 3 millimeters diameter, this may not be so much of a concern. As you're going into small vessels, this is an aggregate of 600 microns of polymeric material, and that's quite a lot in some segments.
Do you see any other limitations of the currently available PLLA-based scaffolds in the use of treatment of long lesions?
I think deliverability can be an issue, predominantly because of the strut thickness that's required to achieve the radial strength these devices can have. And in long lesions, often the vessel may be tortuous, delivery may be challenging.
Do you have any information on future perspectives of second, third generations, which would be more helpful for the treatment of long lesions with fully bioresorbable scaffolds?
Well, of course, there are different varieties. In terms of the polymeric scaffolds, there are thinner strut versions coming out. The dissolved scaffold has a nice feature of so-called self-correction, and that may help in areas where there may not be full apposition initially, and it may help to conform the scaffold to the vessel a bit better. Obviously, we have metallic fully bioresorbable scaffolds that may also be very good in this regard in terms of deliverability to distal anatomies.
And my final question, if we address very long lesions with potentially several fully bioresorbable scaffolds, how long do we need to intend for the dual antiplatelet therapy time?
Well, that's a very, very interesting question. I think it's one that we can't answer at the present time. Most of us at the moment would advocate 12 months of dual antiplatelet therapy, our standard practice for metallic drug-eluting stents. I think many of us, if we put long lengths of metal stent in, might advocate longer in terms of DAPT. and there is no reason to suspect that scaffolds at this stage of development would be any different. And I think that if you would normally prescribe longer for a metallic stented segment, you should probably do the same for a scaffolded segment.
Okay. Nick, I would like to thank you very much for this kind interview on this interesting topic. Thank you.